Hi there, Sharks. How we doing? My name's Alex Lummery,
I'm Taylor Gaines.
and our article is Changes After a Conventional versus an Alternative Therapy Program on Physical, Psychological, and Injury-Related Parameters in Male Youth Soccer Players with Patellar Tendinopathy during return to competition with consumer summary. And a little summary of the article. So, its purpose was to determine whether a conventional, which was 30 minutes of eccentric and isometric exercises and static stretching, or alternative, which was 60 minutes of balance training, eccentric and isometric exercises, static stretching, and dual task progression. Therapy programs are more effective at recovery in athletes with patellar tendinopathy. And its design was a randomized control trial which had the results that the alternative program required a shorter program duration and saw equal or greater changes in performance and pain reduction. But both programs improved the measured outcomes. However, the alternative program was more time efficient in doing so.
So when it comes to our article, it scored a 3 out of 10 on the Pedro scale. So we had 7 flaws. The 7 flaws started with number 3, allocation was concealed. 4, the groups were similar at baseline regarding the most important prognostic indicators. 5, there was blinding of all subjects. 6, there was blinding of all therapists who administered the therapy. 7, there was blinding of all assessors who measured at least one key outcome. 8, measures of at least one key outcome were obtained from more than 85% of the subjects initially allocated to groups. And 9, all subjects for whom outcome measures were available received the treatment or control condition as allocated, or where this was not the case, data for at least one key outcome was analyzed by intention to treat. So ours scored a no on all of those we just mentioned, and that's why the score was a 3 out of 10. And then also for the search details, the method was a clinical trial. It was published in 2023. It was indexed in PubMed, and the language was English. So now when we talk about the 7 flaws, but further explained, for number 3, the concealed allocation, our study, the person who assigned the allocation was aware of which group they were going to. For concealed allocation, the person who determined if a subject was eligible for inclusion in the trial was unaware when this decision was made of which group the subject would be allocated to. So that's why ours was a no. For number 4, baseline comparability, in our study, the con group, they started once they were pain free, while the alt group started the day after diagnosis, regardless of pain level. For the Pedro scale, at a minimum in studies of therapeutic interventions, the report must describe at least one measure of the severity of the condition being treated and at least one key outcome measure at baseline. For ours, they started at different times, but they still use pain, so it's a no. And then for number 5, blinding of subjects. In our study, the subjects were aware of whether they were being allocated to the con or alt group. For Pedro, blinding of subjects involves ensuring that subjects were unable to discriminate whether they had or had not received the treatment. For number 6, blinding of therapists. In our study, therapists were aware of whether they were providing the con or alt treatment. For Pedro, blinding of therapists involves ensuring that therapists were unable to discriminate whether individual subjects had or had not received the treatment. That was a no. And then for number 7, blinding of assessors. In our study, the assessors were aware of whether they were assessing the con or alt treatment outcomes. For Pedro, blinding of assessors involves ensuring that assessors were unable to discriminate whether individual subjects had or had not received the treatment. So that was a no. For number 8, adequate follow-up. In our study, due to absences from both groups, the final treatment did not match the initial allocated treatment time desired. Some baseline diagnostic values were also unavailable. For Pedro, measures of at least one key outcome were obtained from more than 85% of the subjects initially allocated to groups. So that's why ours was a no, because we didn't meet that. And then for number 9, intention to treat analysis. In our study, the attendance for the con group was 89%, while the alt group was 96%. For this to meet Pedro, where the subjects did not receive treatments allocated and where measures of outcomes were available, The analysis was performed as if subjects received the treatment they were allocated to.
And there are also additional study strengths and weaknesses that are separate from the Pedro scoring. Some of the include the treatment period being pretty lengthy, which was 20 weeks in total. And during that 20 weeks, they were tested 4 times during the trial length to observe any changes. The participants also received therapy prior to beginning testing. And all of this together helped us ensure that the participants were safe and good candidates, as well as helping us track the change over time. And then some of the weaknesses were that the subjects were high-level soccer athletes who had previous experience in some of the training durations and methods. So this might cause the results to be a little less applicable to normal people who aren't so experienced in the training durations and methods. And the two groups also had significantly different amounts of load per week, which when you add up the amount of repetitions each group performed, there was a 420 repetition difference between the two, which is pretty significant.
So when it comes to why this study is meaningful to PTs, this study was different than most studies out there about patellar tendinopathy. Most studies usually just use eccentrics and stretching as their method of treatment, but this one that we reviewed used a longer duration treatment and added weights, balance exercises, and coordination exercises in addition to eccentrics and isometrics. And with doing all of that, they found that it reduced pain and improved return to activity faster. So this is meaningful because we could now use those in the clinic in addition to eccentrics and also help us to return players to play faster. But it also was meaningful because it gave an insight on the psychological aspect as well, which a lot of studies usually just do the pain scale for the outcome measure.
So in proposing our new study design, our aim is to improve the Pedro score from a 3 to an 8. So we came up with a plan to correct the criteria of the 3rd, 4th, 5th, 6th, and 7th items. So for Pedro item number 3, for allocation was concealed. The reason this wasn't satisfied was because the person who determined the allocation was completely aware of which group they were going to. So in our new study, to improve this, during the allocation process, we would just ensure that the subjects were all handed a sealed envelope. So the allocator would be unaware of which group they were assigning people to. For Pedro item number 4, the groups were similar at baseline regarding the most important prognostic indicators. This was not true for our article. The two groups were not similar at baseline in terms of pain, and there could be discrepancies between the groups. So a small change we can make was just to have both groups start the day after diagnosis, regardless of pain level, instead of having one group start once they were pain-free and the other start after diagnosis. For Pedro number 5, there were blinding of all subjects. Again, this wasn't satisfied. The subjects were all aware of which group they were being allocated to. So to improve this, we would just make sure the subjects would not be told if they were in the conventional or alternative group, and the groups would be labeled differently than the con and alt, as well as not disclosing how many test groups there are. So all of this together would help create more of an environment to ensure the blinding of all subjects. And then Pedro item number 6 is that there were blinding of all therapists who administered the therapy. This again wasn't true because the therapists were aware of what treatment they were administering. However, this is acceptable to us, and we are not aiming to improve on this because the therapists were involved in performing the pre-screening and being involved in the treatment, all for safety reasons. So if we blinded all the therapists who are administering the treatment, it could create an unsafe environment, which we are not aiming to do in our new study. So we're going to let them know what groups they're treating. And for Pedro item number 7, that there was blinding of all the assessors who measured at least one key outcome. The assessors were all aware of the treatment they were assessing. So to improve on this, we would have separate therapists who did not perform any allocation or any of the therapy, assess outcome and groups, and then we'd label the groups differently, similar to page or item number 5, just to ensure that the blinding was more successful as well. So all of that would help bring our pager score from a 3 to an 8, improving it by 5 points, and that would turn it to an optimal study design, which is more towards what we're aiming for.
And here's our references. Thank you.
And thank you.